epidemiologist and associate professor at the Faculty of Health Sciences at the University of Ottawa. Doctor, thank you so much for your time today. I appreciate you joining us.
It's my pleasure. Thank you.
For an epidemiologist and somebody immersed in this, I'm wondering, when we hear an announcement like this from the province saying, we'll give you the estimated numbers, we're not going to have the update today, there's a lot of people that get very concerned that we don't have the information. How accurate is this information anyway, in terms of the testing that we're doing and the changes around testing protocols? How much stock are you putting into these daily case count updates?
Right. So testing across the country is pretty much broken. People can't get
Yeah.
PCR tests. So we look at the test positivity rate instead. Now, I haven't looked at the Alberta data recently, but it's pretty high in most parts of the country.
Well, 30%.
30%. Well, then we're multiplying whatever cases we have by 5 or so, to get the actual number of people infected. So we're at the point where we can't rely upon the case data to get a true handle on the magnitude of the wave, but we can look at the test positivity rate, the hospitalization rate, and anecdotal evidence to get a sense that the wave has just begun. When the test positivity rate sort of is stable for a number of days, then we can assume that that's when we peaked.
Okay. When we take a look at what's going on with the positivity rate, how does that factor work? Because like in Alberta right now, the only people that are getting PCR tested are people who are in, the more at-risk categories. For example, if I had symptoms and I tested positive on my home rapid antigen test, that's the end of it. I'm positive, stay home. So I don't even get factored in. So how accurate is that positivity, and why is it something that you can rely on in terms of gauging where we are?
Well, you can't rely on any of this stuff. It's all a kind of hand-waving arguments at this point. That's just the official number we have, is it has positivity rate, so we do the best we can with it. It would be great if there was a centralized registry where citizens could report their rapid antigen test results. Even that wouldn't be perfect because people will abuse the system and report fake data. We do the best that we can. The only solid data we have going forward, frankly, is hospitalization data, and that's not going to be sufficient. So going forward, we're going to have to rely increasingly on modeling.
So when we take a look at that, like you say, the one that can't, there's no debating it. If you're in the hospital, you're in the hospital. That's a confirmed case. If you're not, you're not. So that's a pretty solid number. And that one, I think, is the one that people are starting to say is more important. And is that one that we should be focused on as we go through whatever we're going to go through in the next week or month or whatever?
Yeah, that's a discussion that the clinicians are having. I don't agree that it's the primary thing we should focus on. It depends on our goal. If our goal is to preserve the healthcare system, then it matters how full the hospitals are. But that's not our only goal. Our goal is also to manage the extent of the wave. Are we going up? Are we going down? Are we stabilized? So we need case data for that. Also, if you're like me and have an unvaccinated small child at home, you want to know exactly how much into the community transmission has reached, so you know the risk facing your unvaccinated child. So all this information is important, and we're sort of throwing everything at the wall to see what sticks and what we can use to better manage the information flow.
And you mentioned anecdotal. And that one is really interesting because as we see more and more of this coming out, there's reason for optimism, but how much optimism is a question. I'm sure you saw the study out of Ontario, your province, this morning saying that it looks like it's 54% less severe. The chances of severe illness with Omicron appear to be 54% less than they were with Delta. That's positive, obviously, but it's not enough, is it?
Yeah, the devil's in the details. So, there's good news, but it's still more severe than the original Wuhan strain that shut down society in 2020. So we're not out of the woods there. And also, the reason it's less severe is because we have so much vaccination. So Omicron is more likely to result in breakthrough infections. So a greater share of vaccinated people is what's lowering the severity. We still have a large number of unvaccinated people, and it's going to rip through that population. The other shoe that's going to fall is the hypercontagiousness. So if the hospitalization rate is small, as it is, it's actually much smaller than Delta one was, it doesn't matter if enough people get infected all at once. That tiny fraction of a large number is going to be a large number. So that's why we're bracing for an assault on the hospital system. It's so contagious that an extraordinary number of people are going to get infected. Therefore, an extraordinary number of people, although a small proportion, are going to be hospitalized.
Yeah, and there's a study out of South Africa today, and like you say, this is all anecdotal and doesn't translate, but just for example, in wave 2, they said in the first month of each wave, Beta, 41,000 cases, wave 3, Delta, 33,000, wave 4, Omicron, 133,000 cases in Gauteng province in South Africa. So, I mean, it's an orders of magnitude different level of contagiousness.
It really is. And I've seen modeling out of the IHME, the Institute of Health Metrics and Evaluation, suggesting that Canada will see 200,000 cases per day sometime in February. That's a pretty high peak. That's shocking to hear right now, but that's entirely in the cards. The good news is that most of those would be very, very mild, absolutely. Vaccination works, but also that the higher the peak, the shorter the wave. So it'll be done in weeks, not months. So we just have to endure the intensity of that wave for a few weeks.
Yeah, what are you looking at? I mean, again, we're just spitballing here. We're speculating in a lot of cases, but based on what we've seen in other parts of the world, the wave, the so-called wave, seemed to be extremely short, right?
Yeah, that's right. Now, the higher the wave, the shorter it's going to be likely. But we kind of want to make it less high and a little bit wider, ironically, because the higher it goes, the greater threat it is to our healthcare system. So ideally, we shorten it and extend it, just manage the cases. I don't think we'll be able to do that. This thing is so incredibly contagious. It's going to burn through our population pretty fast. South Africa, their spike was early and they came down pretty fast. The UK is still seeing a surge in cases, as is the USA. So the rich parts of the world are experiencing the wave right now and are still climbing to a peak.
What causes that peak to be reached and then the cases to drop off so quickly? Is it just that the virus has managed to target everybody available within that population?
That's exactly right. This is all about susceptible people. Who's susceptible? So in the past, the waves come down because people's behavior changes. You hide inside, you put on your mask or whatever, and it can't get you anymore. Now it's going to just run out of people to infect. And hopefully there's sufficient immunity after that there won't be waves after that. So we cross our fingers that this is the last great battle of COVID. And then in the spring comes, no more waves.
That's the question I wanted to ask you when we talk. I mean, a lot of people say, hey, you know how the Spanish flu ended? It came a more infectious variant that was less severe came out and sort of became the established one, and then we ended up with the flu that we typically get. What has to happen for Omicron to be that, I don't want to call it a silver bullet, but you know what I mean, the thing that takes us to that next stage?
Yeah, I mean, you kind of described it. A few things have to happen. It has to be hypercontagious as it is. It has to be less severe. It's less severe, not as much less severe as I'd like to see. I'd like to see it completely, defanged in every way possible.
Yeah.
And it has to render sufficient immunity lasting a very long time. That's yet to be seen. Coronaviruses in general don't render a lot of immunity. The common cold is a coronavirus and you get reinfected all the time, right? So a lot of things are unknown still. I think with a combination of vaccination, sufficient population immunity, and ongoing public health controls, we can tame this beast sometime in 2022. It's not going away, but it won't be part of our headlines after the summer of 2022, I hope. I pray.
We all hope. A good question here from Gina. And with all of these cases, if you're talking about 200,000 cases a day in Canada, and they're talking about maybe 1 million a day in the United States, ridiculously high numbers. Does that increase the odds of more variants emerging because there's so many cases out there?
Yeah, that's an interesting point. Now, a leading theory of how variants arise is that they tend to infect a handful of immunocompromised people who have chronic infection for a period of months, and the virus gets to try out new things, and that's how the new variants come out. Now, in these rich countries, we tend not to have as many immunocompromised people as vulnerable, so the opportunity for lengthy chronic infection is reduced. And hopefully, if you have someone with a lengthy chronic infection, we have more tools in the hospitals to treat them and lower the infection rate so that they are less likely to become variant farms. It's always possible. But I think the probability is low for the reasons I just described, and also because I think the wave will be over faster, and so there isn't enough as much time for the virus to achieve such mutation.
Okay, last one. How long do we have to wait? We're all being told, hey, we've got to see how this plays out. We can't get ahead of ourselves. We don't know exactly what this wave means, how long it's going to be. What's the timeline you set? When do you think you'll have a better picture based on what we're seeing unfold across our country to say, okay, this is the situation that we're in?
End of January. And I say that because the modeling suggests end of January or early February is the peak. And I think it's probably going to peak sometime in January. And then we'll see, are we on the downslope? If we are, hey, maybe we're done with this thing. And if we're not, then we buckle in for a few more weeks.
Okay, so we can, we've done 2 years. We can do a month, right?
Yeah, I think so.
Okay. Thank you, Doc. I appreciate your time.
Thank you very much.
Yeah, thanks for joining us. That's Dr. Raywat